permanent impairments of the tendinopathies. This course is approved for 6 hours of QME continuing education by the Division of Workers' Compensation. This is your author and narrator, Dr. Perry Carpenter. I hope you enjoy the program. Hi, this is Dr. Perry Carpenter. I'd like to thank you for taking the time to join me on this program. Today's program is entitled Permanent Impairments of the Tendinopathies. And this program is approved for 6 hours of QME continuing education by the Division of Workers' Compensation for qualified medical evaluators of all specialties. Now, you might be thinking, tendinopathies, boy, that is a different and unique topic for a QME continuing education home study program, and you're right. And the reason I decided to create a program on tendinopathies is because we're seeing examinees all the time who have repetitive motion and cumulative trauma injuries that manifest in the form of tendinopathies. Now, the most common tendinopathies seen in the industrial setting involve the upper extremities, and we're going to talk about the upper extremities in this program, including the shoulder, including the elbow, but we're also going to talk about the lower extremity tendinopathies of the knee and also of the ankle. And the reason that this is important is because we're seeing these examinees all the time, and we're providing for permanent impairment for examinees who have tendinopathies, because many of these examinees will never get well and will never recover from these painful and debilitating and degenerative tendinous conditions. But the AMA guides are interesting. The AMA guides themselves make no mention of tendinopathies, and they make no mention of providing for permanent impairments due to tendinopathies. So it's important that we understand the different ways and the different methods that we can use in providing for permanent impairments for these common conditions. So in this program, we're going to go over the following topics. We're going to begin by talking about the development and the anatomy of the tendons of the body, which is a fascinating discussion. And then we're going to talk about the pathophysiology of the tendinopathies and talk about how tendons go bad, how tendons degenerate, and why it is that these have a tendency to go on to become chronic and painful, impairing conditions. You know, it's interesting, in chapter 16 of the AMA guides talk about the medial and lateral epicondylitis conditions. They refer to those conditions as stubborn conditions. And that's a very accurate term, because once these tendinopathies get established, they're very stubborn and they're very recalcitrant to recovery. They seem to respond poorly to treatment, and it's only just now in the last decade or so that treatment advances are catching up with the proper type and the proper modalities of treatment for these conditions. So we will briefly discuss some of the treatment modalities for these conditions, so that when you declare your examinee to be not permanent and stationary and you make a treatment recommendation, you can put forward an evidence-based treatment recommendation. So that's the anatomy and the pathophysiology of the tendinopathies. And then we're going to go through the 4 most common tendinopathies of the shoulder, elbow, knee, and ankle. And we're going to talk about how to provide for permanent impairments under the strict application of the AMA guides for these conditions. And then also, when applicable, we're going to talk about some of the alternative permanent impairment ratings under Alvarez and Guzman that you can employ when appropriate for these examinees when the strict impairment rating does not accurately or adequately capture the impact of the condition on the examinee's activities of daily living. So I have a fascinating program for you that's a bit of a departure from our typical type of continuing education program, but I think it comes at a good time, and I think this is an appropriate time to go back to some medically and anatomically based discussions and sharpen the saw clinically, which will be to the great benefit of your very next examinee. So let's talk briefly now about some statistics of tendinopathies among injured workers in the workplace.
Now, in doing research for this program, I came across over 40 studies relating to tendinopathies due to industrial exposure, and all but a single study involved tendinopathies of the upper extremity, and this involves workers across a variety and across a spectrum of different types of work. So let me just read from some of these studies. Some studies involve what are just generally referred to as workers. I have a study related to Latino poultry workers, another study referring to computer workers with neck or arm pain, sewing machine operators, workers, male meat cutters, nursery school clerks, workers, plastic surgeons, workers in fish processing, workers in the flower industry, spine surgeons, if you can imagine that, iron workers, female cashiers, dental hygienists, and workers across the spectrum of industries. And across all industries, the majority, the great preponderance of the tendinopathies involve the upper extremities at the shoulder and at the elbow, including both the medial and lateral epicondylitis conditions. But in this program, in order to be comprehensive, we're also going to talk about the lower extremity tendinopathies, and we're going to talk about how to provide for permanent impairments also of the lower extremity, but just understand that the majority of cases that you're going to see will involve almost exclusively the upper extremities. So I want to read for you a couple of key quotes from one of these studies. It's entitled Clinical Review on the Socioeconomic Impact of Tendinopathy. And this will help set the stage for our discussion as we continue. And they tell us that highly repetitive movements are commonly observed in daily work tasks, and these highly repetitive movements, coupled with poor workplace ergonomics, place workers at an increased risk of developing tendinopathies. Now, it's interesting. We can see tendinopathies in all populations of people, not just in workers. We see tendinopathies in the general population. We see tendinopathies in the athletic population. But this study provides an interesting distinction about the unique tendinopathies suffered by workers. And that is that a distinction that can be made between workers and athletes is that occupational exposure typically consists of relatively low demand but highly repetitive movements over a longer period of time compared to the athletic exposure, whereas the athletic exposure typically involves high demand but less repetition. So in the athletic environment, the demands and the forces are greater but of a shorter duration, while in the industrial setting, the exposures are over a longer period of time with highly repetitive movements that each of themselves are of relatively low demand, but it's the constant repetition over a long period of time that sets the stage for the chronicity of these tendinopathy conditions. Now, this particular study goes on to tell us that tendinopathy in injured workers is almost exclusively observed in the upper extremity, the most common and arguably the most prevalent of which is the lateral epicondylitis condition. And it's this particular condition that the AMA guys refer to as a stubborn condition. Now, I don't know about you, but I myself have firsthand experience with both lateral and medial epicondylitis conditions. And if you've ever had lateral epicondylitis, you know that it is indeed a stubborn condition. It can take forever to get it figured out as to what's the contributing cause to the condition, and then to figure out what treatments will possibly help this condition. So in addition to my own experience with lateral epicondylitis, I've seen probably hundreds of patients in my clinical practice with this condition. And also on a daily basis, one of my workout partners has a chronic lateral epicondylitis. And he's an interesting guy. He works for the Department of Transportation for the local county, which involves, of course, a lot of repetitive motions of the upper extremities. And so those repetitive motions, coupled with lifting weights in the gym, has set the stage for a chronic lateral epicondylitis condition in him. And I'm familiar with him complaining of his elbow pain, and I've seen firsthand how this has caused him to have to modify most of his upper extremity exercises in the gym. So I may be sharing some examples illustrating some points by using my workout partner as an example. In terms of statistical incidence, a prevalence of 2 to 3% of all workers at any given time may report upper extremity tendinopathies, but the rates can soar depending upon the specific population or the specific type of workplace duties involved. So, for example, the prevalence can soar to as high as 18 to 41% in spine surgeons and in coal miners, respectively. So the prevalence of these upper extremity tendinopathies varies greatly based upon the type of work that the worker is engaged in. Interestingly, age and sex do not seem to play a factor in tendinopathy, with males and females reporting tendinopathy conditions with equal prevalence. And surprisingly, age does not seem to factor in, and the younger populations can suffer from painful and chronic tendinopathies with equal prevalence and frequency as the older populations as well. So these tendinopathies occur frequently, and according to most of the studies that I reviewed in preparation for this program, it seems that tendinopathies are underreported, with many sufferers of tendinopathies not seeking medical care. And most studies seem to suggest that there is a greater prevalence for these tendinopathy conditions than is currently reported in the literature. So it's a big problem, and we're going to be seeing examinees who present to us with tendinopathies even though they don't describe it as such. It's important that you be able to recognize these tendinopathies when they present. So let's get into it and talk about the anatomy and the pathophysiology of these tendinopathies. So first of all, what is a tendon? Well, we all know what tendons are. Tendons are one of the connective tissues. They're specialized connective tissues that connect muscle to bone and transmit the forces generated by muscle to the bone, which results in joint movement. Now, tendons are very stiff structures. They have very little elasticity. Their purpose is to transmit the force created by the muscle and transfer the entirety, 100% of those forces from the muscle to the bone to create movement at the joint. Now, tendons do have some minimal degree of stretch and some minimal tiny degree of elasticity, but you can think of them as a stiff cable, the purpose of which is to take all of the forces that are created at the muscle level and transmit and transfer those forces without alteration and without diminution directly to the bone, resulting in an efficient joint movement. Tendinopathy, therefore, refers to disease of a tendon. The clinical presentation of tendinopathy most commonly includes tenderness on palpation and pain directly in the tendon, often when exercising or with movement or with specific activity. And in the industrial setting, our injured workers are going to tell us about the pain and how the pain follows specific activity at the workplace. Now, tendinopathy is a relatively new term. The term tendinitis has been discarded. And you may have been using the term tendinitis for your entire career in your clinical practice. But the term tendinopathy has replaced the term tendinitis because it's found except for in acute injuries to tendons, Most chronic painful tendon conditions do not involve inflammatory cells. So by histologic study or by biopsy of painful tendons do not have inflammatory cells. There's no macrophages, there's no phagocytes, there's no white blood cells that have migrated into the tendon. There is no inflammation in the tendon except for those cases that involve an acute injury to the tendon. An acute tendon strain will have some inflammation, but most of these cases due to repetitive motion are chronic conditions and there is no inflammation. So the term tendinitis has been discarded in favor of the term tendinopathy. So let's talk a little bit more about the various forms and presentations of the tendinopathies. So tendinopathy refers to any type of disease of the tendon. And we know that tendinopathies can be both acute and more commonly they can be chronic conditions. Now, tendon injuries arise from a combination of both intrinsic and extrinsic factors. And we'll talk about those as we get into this program. So, for example, acute injuries may be predominantly caused by extrinsic factors, whereas in overuse, repetitive trauma, and cumulative trauma cases, it may be caused by multifactorial combinations of both intrinsic and extrinsic factors, where you can have two workers side by side at the same assembly line, both exposed to the same extrinsic factors, and one of those workers gets tendinopathy and the other one does not get tendinopathy. What's the difference between these two workers? Well, the one injured worker has a combination of intrinsic factors that contributes and combines with the extrinsic factors to produce a situation ripe for the development of tendinopathy. So one example of an intrinsic factor for tendinopathies would be poor biomechanics. So, for example, someone that has a limb length discrepancy or a limb malalignment with perhaps hyperpronation of one foot. This is a poor biomechanical situation that may cause increased traction loads acting on the foot and ankle, that may increase the incidence of Achilles, flexor hallucis longus, and tibialis posterior tendinopathies. And we'll talk about the most common intrinsic factors as we go along with the program. For now that we have established the basic definition of the tendinopathies, let's go into a discussion of the anatomy of the tendons so that we can understand the pathophysiology of tendons and how tendons become degenerative. Now, to understand the anatomy of the tendon tissues of the body, it's important that you understand the larger category of which tendons belong to, and that has to do with the connective tissues. So we're going to talk about the connective tissues in some length, but before we do that, remember, if you go all the way back, probably decades and decades for some of you, if you go back to your initial training and your initial coursework in anatomy, you remember probably around the second or third week of your anatomy studies, you learned about the different types of tissue in the body. Remember that there's only 4 types of tissue that make up the entirety of the human body. Those include the epithelial tissues, the connective tissues, and then a small population of the muscle tissues, and then the nervous tissues. So in today's program, we're going to focus on the development of the connective tissues, and we're going to talk about how tendinous tissue is not so different from the other connective tissues of the body. We're going to see that tendon tissue is quite similar, at least in anatomy, to bone, which is another of the connective tissues, quite similar in anatomy to the blood, which is another one of the connective tissues. It's quite similar in anatomy to the ligamentous tissues, which is another of the connective tissues. And so let's talk about the connective tissues. And in order to understand the connective tissues, believe it or not, we're going to go all the way back and trace the development of the connective tissues in the embryo. So remember from your embryology training that in the embryo, we have the three primary germ layers: the innermost endoderm layer, the middle mesoderm layer, and then the ectoderm layer. So let's trace here the development of these layers and focus particularly on the mesoderm, which is going to give rise to all of the connective tissues of the body. And from the connective tissue populations, we're going to see the development of the tendinous structures of the body as they develop from the embryonic mesoderm. So let's go all the way back to the beginning and trace the development of the tendon structures in the embryo. And I think this is important for you because it's going to help you understand the pathophysiology of the tendinopathy conditions. So here we have the female reproductive tract, and this is an ovary here. Here's a fallopian tube. And we see an oocyte being released from the ovary and traveling up in the fallopian tube, where it's met and fertilized by one lucky sperm cell. And then very quickly we see the duplication of the genetic material, and then very rapidly thereafter this zygote, as it's called, begins cell division. So here we have a 2-cell structure and a 4-cell structure and a 64-cell structure. Well, if we trace the travels of this developing zygote, somewhere around the 9th to 10th day, this becomes implanted in the uterine wall, and it continues its growth and development. And here we have the development of the yolk sac, and then below that we're going to have the development of the amniotic cavity right here. And we're going to focus our attention on what happens right here in this layer of cells right here between the amniotic cavity and the yolk sac cavity. So here we have this implanted zygote. At this stage, this is referred to as the blastocyst. And we see that we have the amniotic cavity up here, the yolk sac cavity here, and we have these two layers of cells separating the two cavities. At this stage, this is known as a bilaminar disc of cells. So there's two primary cell layers here. At this stage, we don't have the ectoderm or the endoderm or the mesoderm. We have simply here what's referred to as the epiblast, and then this layer of cells below that is referred to as the hypoblast. So these two layers of cells continue to grow and proliferate, and very quickly we start to see the development of a third middle layer of cells as cells begin to migrate inward from both the epiblast and the hypoblast. So very quickly, as we see the migration of cells from the epiblast and the hypoblast into this middle developing layer, we quickly see that the middle layer becomes a separate and distinct layer of its own. And the epiblast here becomes the embryonic ectoderm. The hypoblast here becomes the embryonic mesoderm. And this middle layer becomes the mesoderm. I'm sorry, did I call this bottom layer mesoderm? I meant to say endoderm. But it's the middle layer here that becomes the mesoderm. And that the mesoderm is going to give rise to all of the connective tissues of the body, including the tendinous structures. So let's trace the development now of the mesoderm a little bit through into the days of the 20th through the 30th day. So here we see the two primary germ layers here. This is the embryonic endoderm. Here we have the embryonic ectoderm. And then in the middle is the development of the embryonic mesoderm. And this section of mesoderm contained right here, that's known as the embryonic mesoderm, with this section of mesoderm that continues outside of the embryo both above and below, that's known as the extraembryonic mesoderm. So our focus of attention here is on the intraembryonic mesoderm, or the embryonic mesoderm. So the embryonic mesoderm can be divided into three basic sections. The most medial section here is known as the paraxial mesoderm. Then we have the middle mesoderm, and then we have the lateral mesoderm. And the connective tissues develop from all three of these sections of the embryonic mesoderm. The paraxial mesoderm is an interesting structure. That's what gives rise to the somites. And if you remember, the somites are what give us the dermatomes, sclerotomes, and myotomes. Well, the somites also give us some of the connective tissues, with the remainder of the connective tissues being contributed by the intermediate and the lateral aspects of the mesoderm. So this mesoderm is going to give us a lot of stuff. It gives us all of the muscles, including the smooth muscle, the cardiac muscle, and the skeletal muscle. It gives us the muscles of the tongue and the pharyngeal arch muscles, such as the muscles of mastication, which are controlled by cranial nerve number 5, and the muscles of facial expression, which are controlled by cranial nerve number 7. The mesoderm also gives us all of the connective tissues. So all of the connective tissues are related embryologically. So for example, some of the connective tissues include the dermis and the subcutaneous layer of the skin. And the subcutaneous layer of the skin is entirely the loose areolar type of connective tissue. It gives us the fibrous connective tissue, such as the tendons and ligaments. And these, of course, are going to be the subject of the remainder of our discussion. The mesoderm also gives us the bone and the cartilage. And you may not recall this, and many people are amazed to remember that both bone and cartilage are connective tissues. And the reason they are considered connective tissues is because they all have the same embryologic origin. And as we're going to see, they all have similar basic anatomic features in common. Now, of course, they have all of their unique and specific anatomic features as well, but they all share common anatomic features, which we'll discuss here in a couple minutes. The dura is derived from the embryonic mesoderm. The endothelium, which is the innermost lining of the blood vessels, the lining of the blood vessels that's in contact with the blood, derives from the mesoderm. And then you may recall that blood itself is considered to be a connective tissue. And the reason it's considered to be a connective tissue is because it derives from the same embryologic progenitor cells as all the other connective tissues do. And blood shares the same anatomic pattern that all of the other connective tissues share, even though it may be counterintuitive that blood does. But when we get to a discussion of the basic structure of the connective tissues, I'll provide an example as to how blood complies and comports with that basic structure, thereby confirming its identity as one of the connective tissues. Also, from the embryonic mesoderm, we get the microglia, such as the astrocytes and ependymal cells of the nervous system. The kidneys are derived from mesoderm, and the adrenal cortex is derived from mesoderm. So with regards to the connective tissues, let's trace the development of the embryonic mesoderm into the various forms and various types of the connective tissues. Now, all of the connective tissues of the body consist of three main components. And what distinguishes one connective tissue from another type of connective tissue is the type and amount and consistency of these three main components. So all connective tissues consist of cells. All connective tissues have some type and some quantity and some arrangement of fibers. within the tissue, and they also have some type, some quantity, and some consistency of what's referred to as ground substance, also sometimes referred to as extracellular matrix. So, for example, if we consider two connective tissues, say, for example, tendons and perhaps bone, well, both of those are connective tissues. They both derive from the embryonic mesoderm, and both of those connective tissues each contain cells. Bones contain cells. Tendons contain cells. In bones, we call those cells osteocytes. In tendons, we call those cells tenocytes. Both bone and tendons contain fibers. And in tendons, we call those fibers collagen fibers. And also in bone, we call those fibers collagen fibers. Both tendons and bones contain extracellular matrix, or some form of ground substance. In bone, the ground substance and the extracellular matrix becomes calcified and gives us that hardened, hard as bone substance, whereas in tendons, the ground substance is more liquid, is more flexible, is more fluid. And so bone, of course, is both visibly and functionally different from tendon, but they share anatomically similar backbone, in that they both have cells, they both have fibers, and they both have ground substance. And all of them are immersed in some quantity of fluid environment within the ground substance. Now, this is important here to understand the anatomic makeup. In today's program, specifically with regards to tendons, it's important that you understand the cellular anatomy, the fiber anatomy, and the anatomy of the ground substance, because each of these represents an area wherein the tendon can go bad, wherein the tendon can become degenerative. We see changes in the cellular structure in tendinopathy. We see changes in the fiber structure in tendinopathy. We see changes in the ground substance structure in tendinopathies. So let's talk, before we get into tendinopathies and the changes that take place in each of these structures, let's further develop the idea of these connective tissues so that you're firmly familiar with these concepts. So here is a diagram that depicts the development of the connective tissues from the embryonic mesoderm. So up in here, consider, up here, here's the embryonic mesoderm, and here's all these mesodermal cells. These are pluripotent, undifferentiated mesodermal cells that have the potential to differentiate and become cells in each of the different types of connective tissues. So over here, we have the hemopoietic stem cell. This stem cell eventually develops into all the red blood cells and the white blood cells, giving us the cell types in the blood that makes blood a connective tissue. In the extracellular matrix of the blood, we have liquid plasma forming the extracellular matrix. Now, we said that the third component of the connective tissue has to do with fibers, and anatomists disagree as to the types of fibers that are present in blood, with some anatomists claiming that there are no fibers in blood, whereas other anatomists claim that the clotting factors of fibrin, fibrinogen, that those soluble fibers that become insoluble fibers, or that come out of solution in the case of a blood clotting scenario, that those are the fibers that constitute the third component of the connective tissue of blood, thereby complying or comporting with the three structural elements found in all of the connective tissues. In bone, the embryonic mesodermal stem cells develop into the osteoblasts, and then the osteoblasts develop into the mature osteocytes. So the primary cell type found in bone is the osteocyte. The extracellular matrix is a ground-like, gel-like ground substance with collagen fibers that is hardened with calcium salts that gives bone its hard as bone composition. Cartilage is one of the connective tissues with the primary cell type, the embryonic mesodermal progenitor cells developing into the chondroblast cells, which is the immature cell. And then the mature cell is the chondrocyte. And the chondrocytes you'll see here are more randomly spaced. They have a lot more spaced compared to the compact and densely packed osteocytes. The extracellular matrix is a gel-like ground substance. It has collagen fibers, just as bone has collagen fibers, but it also has some elastic fibers that make cartilage flexible and spongy. And if you reach up and flex the tip of your nose or the cartilage of your ear, you'll notice that the reason you can bend your ear and let it go and have it rebound back into position is because of the high composition of elastin fibers. And the ground substance and the percentage and type of fibers differs based upon the type of cartilage that we're talking about. Recall that there's 3 different types of cartilage. There's hyaline cartilage at the end of long bones. There's fibrocartilage, such as the discs of the spine and the menisci of the knee. And then there is also elastic cartilage as well, such as the cartilage at the tip of your nose and the cartilage in the pinna of your ear. Finally, to complete our illustration and to discuss the development of the tendons, the embryonic mesodermal cells develop into the primary and most abundant of the cell types, differentiating into the immature fibroblast, which then gives us the fibrocyte. The fibrocyte is responsible for creating all of the connective tissue propers. So let's talk about the different types of what are referred to as connective tissue propers. There's 2 major classifications of connective tissues that constitute the connective tissue propers. The first is the loose types of connective tissue, such as the areolar connective tissue, such as the adipose connective tissue and the reticular connective tissue. Examples of areolar connective tissue are found in the subcutaneous layer of the skin, which is sort of an aqueous, highly water environment. It does contain some collagen fibers. It does contain some elastic fibers. There's also a third type of fiber in the areolar connective tissues known as the reticular fibers, but it's a loosely packed and poorly condensed type of connective tissue. That's why it's referred to as the loose connective tissues. Then we have also the dense connective tissues, of which there's 2 types. There's the regular and the irregular. And it's the tendons and the ligaments that derive from the regular dense connective tissue. So it's referred to as dense regular connective tissue or dense irregular connective tissue. An example of the dense irregular connective tissue is the type of connective tissue that's found in joint capsules and in aponeuroses, where the collagen fibers are more oriented in an irregular fashion compared to the regular alignment, the parallel, regular, repeating alignment of the collagen fibers that are found in tendons and ligaments. So the extracellular matrix consists of a gel-like ground substance. And of course, in tendons and ligaments, there's very little of this gel-like ground substance. The majority of the interior of tendon is occupied by these collagen fibers. Tendons and ligaments are densely packed and cross-linked collagen fibers with a few scattered cells placed throughout the tendon and throughout the ligament, and it's the function of these cells, these fibrocyte cells, to produce both the collagen fibers and to produce the extracellular matrix and to secrete those products extracellularly, which then makes up the structure of the tendon. So all of these connective tissues derive from the embryonic mesoderm.
So, doctors, all of the tendons of the body are connective tissues, and all of the connective tissues of the body derive from the embryonic mesoderm. Now, tendons, like all of the connective tissues in the body, are comprised of three basic components. They're comprised of tendon cells, they're comprised of some degree of collagen fibers, and they're composed of some degree, some quantity, some consistency of extracellular matrix. Now, in our next discussion, we're going to talk about those cells. We're going to talk about those collagen fibers, and we're going to talk about the consistency of the extracellular matrix. And that's going to lead us into our discussion as to the pathophysiology and the degeneration of tendons. It's going to lead us into our discussion of the tendinopathies. And we're going to see what kind of changes take place in the tendon cells, the tenocytes, the tendon cells that cause the tendon to degenerate. We're going to talk about the changes in the collagen fibers that causes the tendon to be painful, to be weaker, and to potentially rupture. And we're going to talk about the changes in the extracellular matrix, which again cause the tendon to change its shape, change its size, change its resistance to tensile loads, and which also, because of the changes in the size and shape of the extracellular matrix, can contribute to various impingement syndromes such as shoulder impingement syndrome, and also contribute to carpal tunnel syndrome because of the thickening and change in size and shape of those tendons, and how that change in size and shape of the tendons contributes to secondary problems just because that those tendons occupy more space in spaces where there is no space to give, such as in the subacromial space in the shoulder and such as in the carpal tunnel in the wrist. So I hope this has been a useful anatomy review for you. I know this takes you way back to your early training in either chiropractic school or osteopathic school or medical school, but I think it's important that we all be on the same page so that when we get to the conclusion of this program, which involves the discussion of the permanent impairments, we know what it is that we're providing permanent impairment for, and we understand that this is a condition, these tendinopathy conditions, that severely impact examinees' ability to perform activities of daily living, so that it's important that we provide accurate permanent impairment ratings for these examinees who will probably never get well from these chronic degenerative tendon conditions. So this is Dr. Perry Carpenter. I want to thank you for taking the time to join me on today's discussion. Look forward to being with you on our next discussion as well, as we continue with our current program entitled Permanent Impairments of the Tendinopathies. For now, I'm wishing you best of success in your career as a qualified medical evaluator.